The indications for a rhinolaryngoscopic examination are among the most frequently seen by a primary care physician. One study cites cough and symptoms referable to the throat as the top 2 symptoms that patients reported to physicians, representing some 17 million patient visits annually. Another recent study demonstrates that diagnostic assessment and patient management decisions are changed 90% of the time following a rhinolaryngoscopic examination. The average exam takes about 4.5 minutes to perform. Here, we're starting with the right nostril. To minimize patient discomfort, the nasal cavity and throat should be anesthetized just prior to insertion of the instrument. Hold the control section in one hand while grasping the insertion tube between the index finger and thumb of your other hand. Lightly place your little finger and ring finger against the patient's cheek to help steady the instrument. Begin by inserting the tube into the anterior nair, directing it along the floor of the nasal cavity. If there's resistance or pain, immediately withdraw. If there's an obstruction, just insert the tube into the other side of the nasal cavity. Here's the recommended path for the exam. Start by viewing the inferior turbinate. Then steer the tip out and up to the middle turbinate and associated meatus. Return the tip to the floor of the nasal cavity and insert it into the posterior third, where you can view the posterior portion of the hard palate and the beginning of the soft palate. Upward deflection of the instrument at this point provides a view of the superior meatus and the sphenoethmoid recess. Return the scope to the floor of the right nasal cavity and advance it slightly forward while rotating counterclockwise to allow for a thorough inspection of the eustachian tube opening and the torus tubarius on the same side of the pharynx. After returning the tip to the floor of the nasal cavity, the contralateral torus can be visualized by rotating the insertion tube 90 degrees toward the opposite nasal cavity while deflecting the tip in the downward direction. Returning the tip to a neutral position and deflecting it slightly superiorly, you can view the nasal pharynx and in children the adenoidal pad. Now deflect the tip downward for your first look at the larynx. Ask the patient to breathe through his or her nose to relax the soft palate, providing additional room for the instrument. As the scope slides over the posterior portion of the soft palate, laterally just beyond the uvula, you'll find the palatine tonsils. Here at the level of the uvula, you can observe the posterior third of the tongue and lingual tonsils. Redirecting your view downward, you can see the epiglottis. The tip should now be at the level of the epiglottis and close to the posterior wall of the oropharynx. From this vantage point, you can identify the major structures of the larynx. Normal chord function can be observed by having the patient phonate E while viewing the vocal cords. At this point, your exam should be complete, with little or no discomfort to the patient. You'll find that the skills needed to perform this procedure are easily learned and improve rapidly with repetition.